22. Drug administration. Ampoule. Small sealed glass container that holds a single dose of parenteral solution in a sterile condition. Angiocath. Catheter inserted directly into the vein for drug administration. Bolus. Concentrated mass of pharmaceutical preparation. Buccal. Pertaining to the inside of the cheek. Drip infusion. Intravenous infusion of a large amount of fluid over a certain period. Enteral. Within the gastrointestinal tract. Extravasation. Discharge or escape of fluid from a vessel into the surrounding tissue that can cause localized vasoconstriction, resulting in sloughing of tissue and tissue necrosis if not reversed with an antidote. Intradermal. Within or between the layers of skin. Intramuscular within the muscle tissue. Intravenous. Within a vein. Intravenous. Injection medication that is delivered by intravenous push, rapid delivery, or intravenous infusion, slow drip of medication over a period of time, directly into the vein. Parenteral or parenterally. Drug administration by a route other than the gastrointestinal, GI, tract, typically by injection through the skin. Rectal. Inserted into the rectum. Subcutaneous. Beneath the skin. Sublingual. Beneath the tongue. Topical. Applied to a certain area of the skin and affecting only the area to which it is applied. Transdermal. Entering through the skin. Venipuncture. Puncture of a vein. Vial. Small glass bottle containing multiple doses of a drug. The 5 rights of drug administration are: 1 right drug, 2 right amount, 3 right patient, 4 right time, 5 right route. DAPTR. To ensure that the right drug is administered, always check the label on the container 3 times, once when the container is removed from the shelf, again when the drug is removed from the container, and a 3rd time when the container is replaced. If you are asked to prepare a drug for another health professional to administer, always show the container to the person who will administer the drug. Always check labels for the expiration date. If the drug is expired, do not use it, and report it. To ensure that the right amount of the drug is used, it must be measured carefully and accurately. The right patient must receive the drug. Use the institution's protocol for patient identifiers before administering the drug. Ask the patient to repeat their name, read and ask the patient's identification number, medical record number, and/or check the patient's birth date as it is printed on the patient's armband. If the patient's name or any other identifiers do not match, stop and get the appropriate corrections made before continuing with the procedure. Once the patient is correctly identified, explain the use of the drug with the patient and how it will be administered for the examination. The drug must be administered at the right time. The physician or practitioner responsible for ordering the drug usually determines the right time for the administration of the drug. Make certain that the drug is administered by the correct route. The physician usually specifies the route by which the drug should be administered. Finally, document the drug you used, the amount, route of administration, date, and time, if the patient refused to take the medication, and all other pertinent information that would be useful when the examination is reviewed. Document any patient drug allergies before drug administration. If the drug is administered parenterally, the site of injection should be included. If an error occurs in the administration of a drug, or if the patient experiences any adverse effects from the drug, make certain to document the details of the incident thoroughly. The Joint Commission has published a do not use list of abbreviations. Here are some common abbreviations. AC means before meals. PC means after meals. BID means twice a day. C- means with. ET means end. G stands for gram. GTT means drop or drops. H stands for hour. HS means at bedtime. Hypo is short for hypodermically. IM means intramuscularly. IV means intravenously. MG stands for milligram. ML stands for milliliter. MM stands for millimeter. OD means in the right eye. OS means in the left eye. PO means by mouth. PRN means as needed. QD means once a day. QH means every hour. Q2H means every 2 hours. Q3H means every 3 hours. TID means 3 times a day. QID means 4 times a day. S- means without. SC stands for subcutaneous. Stat means immediately. The most common units that the radiologic and imaging science professional encounters are the liter, meter, and gram. The most common unit of measurement for liquid medications is the milliliter, the equivalent of a liter. Microgram, mcg, is a unit of weight. 1000 micrograms equals 1 milligram. Milliliter, ml, is a unit of volume. 1 milliliter is the same as 1 cubic centimeter, or 1 cc. 1000 milliliters equals 1 liter, which is also equal to 1000 cubic centimeters. 1000 milligrams equals 1 gram. 1000 grams equals 1 kilogram. 100 milligrams is a tenth of a gram. 10 milligrams is a hundredth of a gram. 1 kilogram is roughly equivalent to 2.2 pounds. Enteral routes include oral, sublingual, buccal, and rectal. The oral route is the most common method of drug administration. This method of administration is medically termed PO, by mouth. Absorption time is longer because the absorption takes place along the entire length of the GI tract. 1. Wash hands thoroughly. 2. Place drug directly into a medicine cup or on a clean paper towel. Do not touch the drug with your hands. 3. Read the label 3 times. 4. Check 2 patient identifiers. 5. Explain the procedure to the patient. Ask the patient about any allergies. 6. Elevate the patient's head. 7. Provide water or liquid to aid in swallowing. 8. Allow the patient to take the drug. 9. Document all relevant information. Administration by the sublingual route means that the drug is placed under the tongue and allowed to dissolve. Administration by the buccal route means that the drug is placed against the mucous membranes of the cheek of the upper or lower jaw for local dissolution and absorption. Administration by the rectal route is an option when the patient is not capable of taking a drug orally. The topical route involves the application of a drug directly onto the skin or mucous membrane. The drug is diffused through the skin or membrane and absorbed into the bloodstream. Drugs for topical application have become available in a unit dose device called a transdermal patch. The patch is applied to the skin and provides a precise dose of drug released over a specified time. Follow these steps when administering topical medication. 1. Wash hands thoroughly. 2. Put on disposable gloves. 3. Read the label 3 times. 4. Check 2 patient identifiers. 5. Explain the procedure to the patient. Ask the patient about any allergies. 6. Apply the amount of drug prescribed. 7. Document all relevant information. The term parenteral means that the drug is administered by a route other than the GI tract, typically by injection using a syringe and needle. Parenteral drugs can be administered in 4 different routes: intradermal, ID, intramuscular, IM, with rapid onset of action, subcutaneous, SQ or sub-Q, with slow and constant absorption, and intravenous, IV, with immediate onset of action. Strict aseptic technique and standard precautions should always be used when drugs are administered with a needle. The Occupational Safety and Health Administration, OSHA, issued standards on blood-borne pathogens, mandating the use of standard precautions and the needle stick safety prevention program. Several types of syringes are used to administer parenteral drugs. The different types of syringes include: 1. Standard hypodermic syringe, 2. Insulin syringe, 3. Tuberculin syringe, and 4. Prefilled syringe. The hypodermic syringe may be used for a variety of medications. The insulin syringe is used for the administration of insulin. The tuberculin syringe is best used for TB intradermal injection or heparin subcutaneous injection. The tuberculin and insulin syringes are designed for situations that require the precise measurement of a small volume of drug. A syringe has 3 parts: 1. The tip, where the needle attaches; 2. The barrel, where the calibration scales are printed and what holds the medication; and 3. The plunger, the inside part that fits into the barrel and changes the pressure within the barrel as it is pulled or pushed in or out of the barrel. The general-purpose syringe comes in a variety of sizes, including 2, 2.5, 3, 5, 10, 20, and 50 ml. Some syringes, such as Luer-Lock syringes, have a locking device on the tip that holds the needle firmly in place. Most hospitals are now using needleless systems for intravenous administration of drugs to reduce the number of needle sticks. All needleless heparin locks have a white ring on the port. The needle has 3 parts: 1. The hub, which is the part that attaches to the syringe; 2. The cannula or shaft, which is the length of the metal part; and 3. The bevel, which is the slanted part at the tip of the needle. Ensure the bevel is always up before insertion into the patient. Needles come in a plastic sheath for safety purposes and are sized according to length and gauge. The gauge, G, refers to the thickness or diameter of the needle. The length refers to the measurement in inches of the shaft portion. The length will vary from 0.25 to 5 inches, the gauge from 14 to 28. The most common gauge needles are 19, 20, 21, 23, and 25 gauge. As a rule, shorter needles are used for subcutaneous injections, and longer needles are used for intramuscular injections. Needles 1 to 1.12 inches in length are most commonly used for intravenous injections. The smaller the diameter of the shaft or the finer the needle is, the larger the gauge number will be. Subcutaneous injections often use a 25 gauge needle, and an intravenous injection generally uses a 20 or 21 gauge needle. A large diameter needle such as an 18 gauge needle is often used to draw a drug or solution into the syringe but is seldom used to inject the drug into the patient. Long bevel needles are generally used for subcutaneous and intramuscular injections, and short bevel needles are used for intravenous injections. An angiocath is a safer device compared with other systems to use when performing venipuncture. An angiocath, also called an intravenous catheter, is used the same as any other needle to puncture the vein. It differs from other systems in that after venipuncture, the user pulls on a sheath, which extracts the needle up through a catheter and into the protective sheath, where it cannot accidentally puncture anyone. An ampoule is a sealed glass container designed to hold a single dose of a drug and is intended for use only once. It is made of clear glass and has a shape with a scored constricted neck that is weakened so that it breaks more easily than other parts of the glass structure. The scoring line of the neck of the ampoule is marked with a colored band indicating the breaking point. The ampoule should be held upright and the top of the neck lightly flicked with a finger until all the drug is in the bottom part of the ampoule. A dry gauze pad is then wrapped around the neck of the ampoule and the top snapped off. Caution should be taken to avoid contaminating the needle by allowing it to touch the outer broken edge of the ampoule when inserting it to draw out the contents. A vial is a small glass or plastic bottle with a sealed rubber cap. Vials are manufactured in different sizes and may contain multiple doses of a drug. First, the metal cap is removed without breaking the outside metal seal, and the exposed rubber stopper is wiped with an alcohol prep pad. This allows for decontamination before the entry of the needle. After a syringe package has been opened, the syringe plunger is pulled back to pull air into the syringe equal to the amount of drug that will be withdrawn from the vial. After the needle package is open, the needle is inserted on the end of the syringe without letting the end of the syringe and the end of the needle touch anything but each other. Carefully remove the needle cap and do not touch the needle. Hold the vial securely in the non-dominant hand and invert it. Insert the needle using the dominant hand without letting the tip of the needle touch anything but the rubber stopper of the vial. With the tip of the needle in the fluid, inject air equal to the volume of drug to be removed. If the needle is above the fluid level in the vial, air instead of solution will be drawn into the syringe. Pull the plunger back until the correct amount of drug has been drawn into the syringe. Next, withdraw the needle and hold the syringe with the needle pointing up while you tap it with your finger to move any air bubbles toward the hub, where it can be expelled by gently pushing on the plunger of the syringe. Intradermal injections are usually administered by injecting the contents of the syringe between the layers of the skin, which are parallel to the skin surface. Intradermal injection sites are on the medial surface of the lower arm, as for testing for exposure to tuberculin. Another site of administration includes the upper back below the shoulder blades, which is usually a site for allergy testing. For an intramuscular injection, the drug is placed into muscle tissue that lies under the subcutaneous tissue layer. This method is utilized when a drug is too irritating to subcutaneous tissues. It is necessary to locate the appropriate injection site for intramuscular injection. It is possible to damage a blood vessel when injecting deeply into the muscle. The most commonly used intramuscular injection sites include the deltoid muscle in the upper arm, the vastus lateralis muscle in the lateral thigh, and the gluteus maximus muscles in the buttocks. In general, the needle length is 1 to 3 inches with a 18 to 25 gauge, depending on the viscosity of the drug to be injected. Intramuscular injections allow for a larger amount of drug to be administered up to 3 ml. The muscle can absorb medications faster than other tissues. A 90-degree angle of insertion is used for intramuscular injections. Use the following steps. 1. Wash hands thoroughly. 2. Put on disposable gloves. 3. Check 2 patient identifiers. 4. Explain the procedure to the patient. Ask the patient about any allergies. 5. Prepare the site by cleansing the skin with an alcohol prep pad using a circular motion and moving from the center to the outside. 6. Inspect the needle for any frayed or sheared areas. If this is noted, properly dispose of the defective needle. 7. With your free hand, retract the skin approximately 1 inch to either side of the site and hold it firmly. 8. Insert the needle at a 90-degree angle. 9. Continue to hold the skin while you gently pull back on the plunger to make certain the needle is not in a blood vessel. 10. If blood does not appear in the syringe, slowly inject the drug. If blood appears in the syringe, remove the needle and prepare another site for injection. 11. Withdraw the needle while releasing the tension on the skin. 12. Apply gentle pressure to the site with a gauze. 13. Unless contraindicated, massage the injection site. 14. Dispose of the syringe and needle properly. 15. Document all relevant information. When a subcutaneous injection is administered, the drug is placed under the skin into the subcutaneous tissue that lies under the epidermal layers. The thickness of the subcutaneous tissue depends on whether the patient is obese and, if so, to what degree. The most commonly used subcutaneous sites include the anterior thigh, upper back below the shoulder blades, outer upper arm, and abdomen. Subcutaneous absorption is slower than the intramuscular route because of the lack of vascularity. For average-size patients, a 25-gauge, 5/8-inch needle at a 45-degree angle of insertion is generally used. For above-average-size patients, a 25-gauge, 1/2-inch needle at a 90-degree angle of insertion is generally used. Follow these steps. 1. Wash hands thoroughly. 2. Put on disposable gloves. 3. Check 2 patient identifiers. 4. Explain the procedure to the patient. Ask the patient about any allergies. 5. Prepare the site by cleansing it with an alcohol prep pad using a circular motion and moving from the center to the outside. 6. Inspect the needle for any frayed or sheared areas. If this is noted, properly dispose of the defective needle. 7. With your free hand, pinch the skin gently together, and insert the needle quickly at the appropriate angle for the patient's size. 8. Release the skin and pull back on the syringe plunger to make certain the needle is not in a blood vessel. 9. Inject drug slowly, and quickly withdraw the needle at the same angle used for insertion. 10. Dispose of the syringe and needle properly. 11. Document all relevant information. When an intravenous injection is administered, the drug is placed directly into a vein and a rapid action occurs in minutes. Most emergency drugs, chemotherapy drugs, and contrast media are introduced using the intravenous route. When injecting an intravenous drug or contrast agent, the patient cannot be left alone. Reactions can occur immediately, and any changes in the patient's vital signs or behavior must be reported to a physician immediately and recorded in the patient's medical record. Injection safety. 1. Adhere to facility protocols for infection control and aseptic technique. 2. Do not administer drugs or medications from a syringe to multiple patients. 1 needle, 1 syringe, 1 patient. 3. Use intravenous or drip infusion sets for 1 patient only and dispose after use. 4. Use single-dose vials whenever possible. 5. If multi-dose vials are used, both needle and syringe used to access the multi-dose vial must be sterile. For most intravenous injections, veins found within the antecubital fossa should be used as they are generally large, easy to access, and durable enough to withstand injections. The most commonly used intravenous injection sites include the median cubital, cephalic, and basilic veins. Median cubital vein is the superficial vein that lies over the cubital fossa and serves as an anastomosis between the cephalic and basilic veins. The location of the cephalic vein is on the lateral side of the forearm and the basilic vein can be located on the medial side of the anterior surface of the arm, elbow, and forearm. The cephalic and basilic veins can also be located on the posterior surface of the hand. The veins in the lower extremities should be used only in an emergency. If using the vein that lies over the cubital fossa, ensure that the patient's arm is immobilized unless an intravenous catheter is used instead of a needle. The needle length and gauge depend on the viscosity of the drug, the site selected, and the specific method of injection. Injection of contrast media with a small gauge needle may cause leakage of the contrast into surrounding tissues. It is best to use a larger gauge needle 18 to 20 gauge when injecting contrast. Inappropriate sites for venipuncture include scarred areas, the arm on side of a mastectomy, edematous areas, hematomas, an arm getting a blood transfusion, an arm with a fistula or vascular graft, a bifurcated vein, a vein valve, and sites above an intravenous access device. One of the most commonly used intravenous needles is the winged tip or butterfly needle, which is manufactured in lengths of 1/4 to 1/14 inch and 18 to 25 gauge. An 18 to 20 gauge butterfly needle is commonly used for adults, and 22 to 23 gauge devices are more commonly used for pediatric patients. The butterfly needle has tubing 3 to 12 inches long that extends from the needle to the hub. Winged needles are usually 21 gauge, green, or 23 gauge, blue, and best used for shallow veins. If extravasation occurs, the first step is to remove the needle, apply pressure to the injection site, and apply moist heat pack to relieve the discomfort. If the extravasation involves a corrosive drug, immediate attention is needed to prevent tissue necrosis. When a corrosive drug infiltrates the tissue, a cold pack rather than heat should be applied to the site, and the physician and pharmacy must be notified. Steps involved in venipuncture and intravenous drug injection. 1. Wash hands thoroughly. 2. Check 2 patient identifiers. 3. Explain the procedure to the patient. Ask the patient about any allergies. 4. Assemble all needed supplies for venipuncture to include but not limited to a topical anesthetic spray, gauze, tape, and/or adhesive bandage strip, tourniquet, appropriate needle or butterfly, syringe or intravenous catheter. Inspect the bevel for any frayed or sheared areas. If this is noted, properly dispose of the defective needle. Ensure the needle size is appropriate for the patient. Pediatric patients may require a smaller needle gauge in comparison with one for an adult. If using a butterfly needle, include in the preparation flushing the needle with saline before administering the drug. 5. Put on disposable gloves. 6. Once an appropriate site for venipuncture has been selected, clean it with an alcohol prep pad using a circular motion while moving from the center to the outside. Allow the area to dry before inserting the needle. 30 seconds is appropriate amount of drying time. Do not blow or fan the area in an attempt to dry the area. Inadequate drying may cause the patient to feel a stinging sensation from the alcohol prep pad. Once the site has been cleaned, you cannot touch the venipuncture site with or without gloves. Touching the area contaminates it. Cleaning the area with an alcohol prep pad will be required again. 7. Apply a tourniquet above the site using sufficient tension to impede the flow of blood in the vein. Ensure that the ends of the tourniquet do not dangle over the proposed venipuncture site. Geriatric patients may have extremely sensitive skin that may tear under the pressure of the tourniquet. Ask the patient to open and close the fist to distend the vein fully. Palpate the vein if necessary. When the vein has been identified, ask the patient to hold the fist in a clenched position. 8. To stabilize the median cephalic vein, place your thumb on the tissue just above or below the site and gently pull the skin and vein toward the patient's hand if below and toward the patient's shoulder if above. Stabilizing the vein prevents the vein from rolling under the pressure of the needle entering the vein. Geriatric patients have veins that tend to roll and may be more fragile. 9. Hold the needle with the bevel facing upward so that you can see the opening of the bevel. When using a butterfly needle, pinch the wings together tightly toward you. The reason the wings of the needle are held to allow you to grasp the needle close to the end to ensure accurate placement in the vein. 10. Insert the needle next to the vein at a 15 to 30 degree angle and gently advance it into the vein. If the needle is positioned correctly, blood will flow back into the tubing. If there is only a flash of blood in the tubing, gently reposition the needle. If the needle is pulled out during the reposition, you will need to start again. Do not reinsert the needle if it has exited the vein and skin. 11. If the tubing of the butterfly needle has not previously been filled with the solution, allow the blood to flow from the hub before attaching the syringe to ensure that no air bubbles are contained in the system. 12. If using an intravenous catheter to inject the solution, insert the needle next to the vein at a 15 to 30 degree angle, and gently advance into the vein once the flashback of blood is seen in the chamber of the catheter. 13. On flashback visualization, lower the catheter to be parallel with the skin. Advance the entire catheter unit before threading the flexible plastic portion of the catheter into the vein. Advance the plastic sheath of the catheter into the vein while pulling the needle back away from the sheath while maintaining a taut pressure on the patient's skin. Most catheters have a spring release button to retract the needle. Once the needle is retracted, blood will flow freely. Dispose of the needle properly. 14. Remove the tourniquet and inject the drug. If using the catheter, you will need to apply a syringe to administer the drug using the facility procedure. 15. Unless otherwise instructed, remove the needle and apply gentle pressure to the site with a gauze. 16. If using the catheter, remove the plastic sheath that is in the patient's vein and apply gentle pressure with gauze once the catheter is removed. 17. Dispose of the syringe and needle or butterfly needle properly. 18. Document all relevant information. Proper tourniquet application. 1. Ask the patient about any allergies to latex. Do not use a latex tourniquet if the patient has a latex allergy. If possible, use disposable, single-use tourniquets. 2. Apply the tourniquet 3 to 4 inches above the area for venipuncture or for drug injection. The vein will fill with blood, which will make vein location and identification easier. 3. If using the median cephalic vein in the patient's arm, place the tourniquet under the patient's arm with an end in each hand. The tourniquet should be flat under the patient's arm. 4. Holding tension on both ends of the tourniquet, swap the two ends. Pull the ends upward, forming an X. 5. Pinch the X with the left thumb and index finger. Fold one end on the right side over itself. The left side should be slightly tighter than the other. 6. Tuck the right double-folded end halfway under the left next to the pinched X, leaving both ends point away from the injection site. 7. Do not leave the tourniquet on for more than 2 minutes. If using the tourniquet for vein selection, a minute or less is appropriate. Drugs that are administered by the intravenous route may be injected using one of 3 methods. One method involves a single administration in which the drug is injected slowly. A second method involves the administration of a drug by intravenous bolus or intravenous push. The term bolus refers to the amount of fluid injected, and intravenous push refers to a rapid injection. This method is generally used in an emergency when immediate drug action is required. The third method of administration involves the intravenous infusion of a large volume of fluid. This method is sometimes called a drip infusion, and it requires some additional equipment to ensure accurate delivery of the intravenous solution. Steps involved in setting up an intravenous or drip infusion drug administration. 1. Wash hands thoroughly. 2. Check 2 patient identifiers. 3. Explain the procedure to the patient. 4. Assemble all needed supplies. 5. Check the expiration date. Remove the administration set from the box and straighten the tubing while checking for any cracks or holes. 6. Slide the clamp up to the drip chamber and close it. 7. If the intravenous solution to be infused is contained in a bottle, place the bottle on a hard surface and remove the metal cap and rubber diaphragm that covers the rubber stopper. Wipe the rubber stopper with an alcohol prep pad. Remove the protective cap from the spike on the drip chamber, and firmly insert the spike into the center of the bottle's rubber stopper. Check to make certain the clamp is closed and invert the bottle. Hang the bottle on the intravenous pole and squeeze the drip chamber until it is half full. 8. If the intravenous solution to be infused is contained in a plastic bag rather than a bottle, place the bag on a hard surface, remove the protective cap from the tubing insertion port on the bag, and wipe it with an alcohol prep pad. Remove the protective cap from the spike on the drip chamber of the tubing and insert the spike into the port. Check again to make certain the clamp is closed. Hang the bag on the intravenous pole 18 to 24 inches above the site, and squeeze the drip chamber until it is half full. 9. Prime all tubing before using the intravenous setup by removing the protective cap from the end of the tubing and holding it over a sink or waste basket. Take care to preserve the sterility of the cap and end of the tubing. 10. Release the clamp and allow the solution to run freely until all air bubbles are cleared from the tubing. 11. Reclamp the tubing to stop the flow and replace the protective cap over the end of the tubing. 12. Loop the tubing over the intravenous pole until the injection site has been selected and the venipuncture is complete. 13. Document all relevant information. Unless otherwise instructed by a physician, 10 to 20 drops per minute is an acceptable flow rate. Patients receiving intravenous infusion should be monitored closely. If the flow stops, the site of injection should be checked for signs of infiltration. If evidence such as swelling and pain around the injection site exists, the infusion must be stopped immediately, the needle removed, and a warm pack applied to the area. An intravenous pump and controller are devices used to regulate the flow rate electronically. A controller regulates the flow rate by counting the drops and compressing the intravenous tubing to adjust the flow. A pump propels the solution through the tubing at the desired rate under pressure. The pump is more accurate than the controller. Both devices have alarms that sound a beep or flash a light when the infusion fails to flow at the prescribed flow rate.